I think that we should get going in the service of time. Thanks for coming, everybody. I know that we're going to have some other folks walking, kind of coming in and out from Capri. Staff is driving up. So I'd like to introduce Justine Reel. She is an assistant professor at the University of Utah and a licensed professional counselor in the state of Utah. She served as the exercise addiction director and primary therapist for an eating disorder treatment facility in Salt Lake, and has treated eating disorder clients in an inpatient, residential, intensive outpatient, and outpatient setting. Most currently in an outpatient private practice setting, she provides counseling and sports psychology consulting for Olympic winter sport athletes, over-exercisers, and student athletes as a member of the University of Utah Student Athlete Wellness Team. Dr. Reel authored The Hidden Faces of Eating Disorders and Body Image. Yes, that's fantastic. And Eating Disorders, and has a second book, Eating Disorders, Causes, Treatment, and Prevention, slated for publication in 2012. To bring greater awareness to the issue of exercise and eating disorder treatment, she founded the NEDA Exercise Special Interest Group. She recently served as the Professional Standards, I should have known that when I just asked you that. She recently served as the Professional Standards Division Head on the Association of Applied Sports Psychology Executive Board. She earned her PhD and master's degree from the University of North Carolina at Greensboro and is from Cary, North Carolina. She has been appointed to the Journal of Clinical Sports Psychology, Journal of Sports Psychology in Action, and Eating Disorders, Prevention and Treatment editorial boards, and is a section editor for the Women in Sport and Physical Activity Journal. She is a founding board member and former vice president of the Utah chapter of the International Association of Eating Disorder Professionals. And today, she's going to be presenting on promoting intuitive exercise, exercise education, and eating disorder treatment. And one thing I want to say is that I'm just delighted that Justine's here, because even though we've been treating eating disorders in the field for, I want to say, really only about 20 years, exercise and eating disorders is still a very hot topic and openly disputed amongst the professionals in the field, and I just think it's a topic that even here at Rosewood we need to be discussing more openly. So I have asked Dr. Reel to be as controversial as she wants to be, just to open up the discussion with us as we continue to formulate our own opinions and directions on where we go with exercise and treating folks of all BMIs in the field and all levels of care. So I just want to say thank you for coming, and I will turn it over to you and let us know if you need anything from us.
Great. And just let me know as far as time. I think all of you are probably going somewhere at 1:15.
Actually, some will be skedaddling out at 1:25 or 1:20, and the rest will be around till 1:30. Okay. Is that right, Hunter? Okay.
So we want to make sure that this is interactive as possible. I'm here for you, and so I want you to see this as a workshop, and if there are things that you're already doing, hopefully it's a reinforcement of those things, and so that as staff members you can be more intentional as you go forward and feel more confident about it. There might be other things that are questions that we raise and we have a little bit of a discussion about as well. And thank you so much, Libby, for your warm introduction and for bringing me out here. I'm delighted to be here. And after tomorrow, I'll actually be here for a professional on-site, so I'll be able to learn a little bit more about what you're doing. So I'm excited for that. In terms of our goals for today, we'll keep it pretty simple in terms of 3 main things that we want to accomplish. One is to characterize what exercise addiction or abusing exercise means, and all of the different terms that are out there for it, kind of hashing through those. We also want to look at how do we assess for this. So from the very time that the client calls and is interested in admitting at Rosewood, what can we do to get some information about them? What can we do, regardless of what our role is at Rosewood, to assess throughout their treatment? And as they're getting ready to discharge, are there some things that we can do as well? And then our final goal would be to look at the role that exercise can play or should play in treatment. So Libby already mentioned that I wear multiple hats. Primarily my full-time job is an assistant professor at the University of Utah. And a lot of the work that I'm doing right now is in the prevention area. And so I'm actually referring to folks like you as opposed to treating everyone who calls for an appointment. I do have a small private practice. It's 100% eating disorder clients. And the types of referrals that I tend to get are athletes who have eating disorders or body image issues, whether it be winter sport athletes that are struggling with body image and it's affecting their concentration. And so I'm working with them doing both sports psychology and counseling. Or individuals who have eating disorders and also have exercise issues over exercise. So those tend to be the majority of the people that I treat at the current time. But like I said, my primary focus right now is prevention and appropriate referral and finding resources for all the individuals that are out there. As I was telling Libby, I get calls 1 or 2 a day from parents who are trying to find treatment venues for their daughters and sons. So how did we get here? How do we even think about having exercise be something that's abused? I mean, if we think historically, exercise was a way to move our bodies from point A to point B, or it was something that allowed us to be involved in tasks, whether it be lift a box or move up the stairs. But if we think about it, and I wanted to start with some material to allow you to get a head start on your lunch before I encourage you to talk. But if we think about it, if we have media that's showing us images on the left of ultra-thin models that are seen as beautiful, well, a few seconds later, we're showing images that are inundated with commercials of $6 burgers that are packed with over 1,000 kilocalories of energy. What do we expect? So if we put those two images together, what do we get? Probably Paris Hilton in a Carl's Jr. ad. So we're expected to look like a model while eating a $6 burger. So in a sense, overindulgence is rewarded in our society, but discipline is also rewarded. And so if you can hold off, if you can restrain yourselves from eating, if you can show the self-control of exercising, and you're given a compliment. Well, that's great that you were able to hold off. You were able to not take a cookie from that buffet over there. You know, you were able to exercise 5 miles even though you're really hurt. And so we reward that mentality. And ultimately, a dieting mentality is normalized within our culture. So we're seen as, you know, trying to work hard, trying to restrain and restrict what we eat, and what means that we're having 0-calorie sodas in the skinny can, and at the same time we're running so we can look like a skinny can. Then we have Biggest Loser shows. So we have the shows where we're showcasing weight loss. And exercise is used as the vehicle or the magic bullet for getting there to your goal. So we have these individuals that come in and are clinically obese, and we're putting them on exercise regimens that mirror those of celebrities, where they're working with personal trainers, exerting themselves for hours and hours, overtraining to the point that they are getting overtraining and stress fractures and injuries, and on an exercise plan that isn't possibly sustainable. And so all of the focus is on weight loss and using exercise to convert to pounds lost. And how quickly can we lose this weight? And the faster we can lose it, and the more we can lose, the better, without weight maintenance or any type of stabilization being in the picture. And so certainly in terms of our exercise, that motivation is strictly all about burning calories, about weight loss. And so what we'll be talking about today is all about motivations for exercise. What is the individual's mindset? What is our mindset when we move our body? What is our client's mindset when they move their bodies? And so when we think about this mentality, the dieting mentality, the exercise for weight loss as the sole purpose, that really guides our discussion. So in the interest of full disclosure, I should probably tell you a little bit about my movement history. And as Libby mentioned, I'm from Cary, North Carolina. And so pools are pretty big there, as I'm sure they are here in Arizona. And I was afraid of the water until about the age 7 or 8. In fact, I was the little girl that would walk around the perimeter of the pool trying not to get anywhere near the water. And my mother enrolled me on the swim team because she felt like it would be cheap swim lessons. And so when my parents came to the first swim meet, they wondered if I'd even be able to make it to the other side of the pool. And I don't think I dove in or anything like that, but I did make it to the other side. And I had a propensity for the breaststroke. And so I found that swimming as a form of movement it became a source of self-confidence for me. It was something where I could learn to have achievement. I was able to make friends on the swim team. I was able to compete with boys and girls. And so I was able to develop a competitive spirit. I had enjoyment for movement. Health was probably a benefit, but I didn't care, being a young child and an adolescent. But certainly there were multiple motivations to move. As a college student, all of a sudden my mindset started to change. And I was exercising beyond the point that I really wanted to in terms of swimming. I was moving not because I wanted to, but because I felt like I had to. And so I was doing more and more laps because I felt like, well, this isn't good enough. This isn't good enough. I need to do more and more and more. So I was able to see that shift in myself for my mindset for exercise. Now I really don't swim a lot in Utah. And part of that is because I would be in an indoor pool, and I don't feel like it would be as much of an enjoyment for me. So I do it when I'm on vacation. I always do it on my own terms now, because it's all about moving and being outside. But for myself, I was able to see one sport or one activity where I could have multiple mindset shifts. And I'm sure you've seen that throughout your lives too. So now that I've shared, it's your turn. So how many of you played a sport or danced or did some type of movement growing up? Raise your hand. Okay. And now, so that's just about everybody. Was there anybody who's never played a sport in their life? Okay, so I think we've got everybody covered. So now, how many of you at the current day exercise regularly? Okay, are any of you wondering what does exercise regularly mean? So if we ask CDC how much exercise should adults get, what would the Centers for Disease Control tell us?
30 minutes a day.
30 minutes a day. They actually say 150 minutes a week of moderate exercise, plus 2 minutes of strength, or 2 days worth of strength training. So they say that as long as you exercise at least 10 minutes at a time, that counts. And so, it works out to be about 30 minutes for 5 days a week. So now that I've said 30 minutes, about 5 days a week, how many of you think you get that in terms of movement? And 10 minutes at a time counts. Okay.
Movement or like exercise?
Exercise, moderate movement. Now, if we're talking vigorous, so moderate would be like walking. And so vigorous would be like running or jogging. And with vigorous, the definition or the recommendation is a little bit different. They say you can do 75 minutes for vigorous. And so that would be just your general adult. That would not be for our clients with eating disorder. That would just be generally speaking. And so it's interesting to me because when I developed an exercise education program at the eating disorder facility that I worked at in Salt Lake City, my clients would often say to me, I don't ever get any exercise now that I'm here. I just sit around all the time. And I said, well, it's interesting that you're saying that to me because actually, not only are you meeting the requirement of 150 minutes a day and you're getting 2 days of strength training, but you're surpassing what the average American is getting by a long shot. But it's all about how you view what counts as exercise. Your point is right on target. Is this exercise or is this movement? And what gets to count? And so we'll be talking a little bit about that. So how many of you currently feel like you're working with at least one person who has exercise issues? Okay, so that's just about everybody. Okay, and how many of you think it's possible to abuse exercise or have too much exercise? Okay, is there anybody who disagrees with that statement? Okay, well then I can move on. I don't have to convince you that there could be sometimes that are problems.
Don't swim coaches believe that?
Swim coaches?
Yeah, I always read that they're the one sport that overtrained. My daughter was a swimmer, and they just killed the. I mean,
absolutely.
She was always.
Well, it's just inherent in the sport of swimming. You know, where you have morning practice and you have afternoon practices, and it's just.
But
it's overtraining.
I read some of the exercise physiology stuff, and there was, I guess, science on overtraining.
Yep.
And the exercise physiologists don't understand why it doesn't apply to swimmers, at least when I was into reading those, when she was doing it.
Yeah, and overtraining is possible in swimming, absolutely. But you're right, that swim coaches, they have a different outlook on things and what counts. I'm a former swim coach myself, and so I constantly had to walk that balance of what is healthy and what is really necessary in terms of training so that my swimmers can be ready to get in the water. And at the same time, I don't want them to have a lot of injuries and illness. And so I struggle with a lot of swimmers that would develop sickness and mono from just being around the pool. And at the same time, we had to get them ready, especially the longer distance swimmers. So yeah, you're onto something there. So what are some terms that you've heard in terms that characterize over exercise or exercise abuse? Are there other things that you've heard?
Term-wise? Like
compulsive exerciser,
exercise bulimia.
Exercise bulimia, orthorexia.
No pain, no gain.
Yeah, no pain, no gain. Yeah, there's all kinds of terms out there, and this is not an exhaustive list, but some of the more common ones that we either see in the literature or in newspapers or that the media talks about. Exercise addiction was coined in the 1980s and really characterizes the stimulant effect that exercise can have, where there's that feeling of euphoria, very similar to what is described in substance abuse or addiction. Exercise bulimia is not really a formal term, but it's used a lot by the media and has been really popularized. Exercise dependence, we'll spend a little bit more time talking about that term. That was actually coined by Veely in 1987 in response to, have any of you heard of the runner's high? Mm-hmm. The runner's high had been used quite a bit in the 70s to talk about runners who had become disconnected with their bodies. They would be running and running and running. They'd experience being in the zone. Have any of you ever felt this before? And so all of a sudden you're just running and it's effortless. And it's wonderful. But your body doesn't really know what's happening because you're disconnected. Your mind is disconnected from your body. And so this runner's high was always seen as kind of a positive term, a positive condition. And so the term exercise dependence was coined because the feeling of compulsion was missing from the term runner's high. And so it does get to the more negative connotations associated with having an addictive or abusive relationship with exercise. So all of these terms are out there and have been used quite a bit. When we look at exercise dependence specifically, do you know the difference between primary and secondary exercise dependence? Have you heard those terms before? Does anybody know? So primary exercise dependence is those individuals that have exercise issues, but they don't necessarily have an eating disorder. So their primary issue is exercise. And I've worked with some of these folks. And these are the individuals that have exercise problems, but they're not necessarily exercising to lose weight or to burn calories or anything like that, but they still feel that sense of being compelled to do it. Whereas secondary exercise dependence, the primary diagnosis is eating disorders. It could be anorexia nervosa, bulimia nervosa, eating disorder not otherwise specified. We really don't see it as much for binge eating disorder, but that would be the primary diagnosis. And if we're looking at a population like this, let's say, I know some of you work in the different levels of care, but let's say residential. What percent do you think of the clients would have some type of exercise issues or exercise dependence?
Half.
Half?
I'd say 90% of the bulimia or purging type.
The purging type. So, depending on the study, anywhere from about a 1/3 to all the way up to 80%. And one study found that 80% of anorexia nervosa clients in a residential facility and 55% of bulimia clients had it. I know in my own experience, I felt like everybody did when I was working in an eating disorder treatment facility, but it may have been because I was the primary therapist that was seeing all of those folks. So I felt like, gosh, they keep coming. But I think that the point that we have here is very much an issue, and it's something that we need to address. And we have to be really careful to make sure that we're considering this as a part of a comprehensive treatment package that we're providing to our clients coming in. So this chart right here, I'm just trying to illustrate that we have all of these terms that we've talked about, but the latest trend is for exercise researchers to refer to dysfunctional exercise. And the reason for that is to really get to the mindset and think about it more broadly. So think about it in terms of it can affect anybody. Anybody could have a dysfunctional relationship with food. Anybody could have a dysfunctional relationship with exercise. And so right now, if we go out there and we're talking about it, we usually use the term dysfunctional exercise. And when we're looking at it, it's all the things that we already knew about related to exercise dependence. So being compulsive, exercise being something that is seen as a sense of euphoria or something that can be a stimulant, and trying to avoid the negative feelings associated with not moving or not exercising. So I wanted to ask you guys, when do you know that you have a client that has dysfunctional exercise or exercise issues?
When they say things like, yeah, I broke my foot, but I never missed a run.
Yes. So they keep running despite having injury, despite having sickness, despite being overtired.
When it gets in the right way of their social life, when they're asked to do something, they'll try to exercise.
So exercise becomes the top priority. And so they no longer are going on dates. They're turning down offers to go out with friends. They're missing family obligations. They're missing work in some cases. I've worked with a lot of individuals that become unemployed because their work schedule just isn't working into their exercise schedule. It's just not, there's a little clash there. I work with some college students right now. One, when she first came in to treatment, she had her backpack with her. And I said, oh, what's in your backpack? She opened it up and she had some folders with her class materials and her readings. And then in between each section she had a set of exercise clothes. And so she would go to exercise, she would go to the exercise, then she would go to her class, and then she would go and exercise again, and she'd go to the next class. And then she revealed that if the exercise session was not good enough the first time, she'd probably miss class. And so it was on and on. So it was very planful. What about a rigid routine? Have you seen individuals that say, hey, this is the only thing that counts. I can only run, that is the only thing that I can do. Okay. Yeah, so it's rigid, it's routine, I need more and more and more. So there's this tolerance effect where this is not good enough. 3 miles was okay 2 weeks ago, but now I must do 5 miles or more. And so there's this increasing need to increase whatever is being done, increasingly more rigid. There tends to be a withdrawal. What happens for folks that have dysfunctional exercise and then they're not able to exercise? You work with them. What happens? Anxiety, stress, muscle aches.
They can't put on weight.
Are they friendly? Are they a little grumpy? Yeah, we tend to see a lot of mood swings, so that anxiety is full force. There's some irritability, and in terms of having them be a roommate or group member, there's a lot of grumbling, but they're feeling compelled to do it. And so to them, they feel like there's no other choice. This is what I have to do. And if I don't, I'm just going to go crazy. And so the clients themselves are recognizing the negative emotions that happen when they're unable to do it. So, as has been mentioned, they're exercising regardless of if they're on vacation. They're strategizing, let me make sure there's a fitness room that has everything I need with all the proper machines, and I need to make sure that everything's set, otherwise I'm not going to go. And generally speaking, there's that mindset of I'm exercising to purge. And I think the thing that's really dangerous about this, and I don't know if you all agree with this, is exercise is socially desirable. It's a lot more socially desirable than self-induced vomiting, right? Or abusing laxatives. And so they're probably getting different messages on the outside than our staff is giving them. And so it's difficult because when we look at this, it makes it that much more challenging. So what is the problem? I mean, exercise is good. I mean, there's a lot of health benefits that we know about. We're told that we should all exercise more, that we should be better and move more. We have this obesity epidemic in society. So what's the problem?
See, it's used as a tool to avoid the issues that they don't want to deal with. It's a tool.
Yeah. So it's a negative coping strategy. What else?
Just like anything else, if it's causing a problem in other areas of life, family, social, physical, emotional, it's a problem. And if you have to lie about it, it's a problem.
Right. So it's becoming the center focus at the exclusion of these other areas, of these other priorities. And there's a tendency to have to minimize what we're doing. Are there any other problems?
When it becomes excessive.
Okay.
Too much of it, they won't never know.
Yeah. So we've already mentioned that there could be job loss. We've already mentioned there could be injuries that are occurring. So we have all of these physical and we have psychological effects too. The fatigue, the anxiety. So this is a picture that was done in kind of an art therapy setting with a client who was struggling with exercise. She was simply asked, as was the entire art therapy group, draw your relationship with exercise. And this is what she came up with. And I think this is a really powerful one because it gets to the metaphor of feeling imprisoned with exercise. And so as you can see with this one, the client has all these other things outside. As you were mentioning, these other priorities get pushed. So joy, goals, friends, fun, school, romance, and spontaneity is at the top. And then she's inside this exercise jail with all of these negative emotions that she's dealing with. So my question is, historically, we just wouldn't have our clients move. This is time for bed rest. So kind of looking at the inpatient model or medical model, being in the hospital. So do we think exercise is good in treatment? Do we think it's bad and should be avoided at all costs? So in the interest of time, I'm not going to take a lot of time to set up our debate. But I'm going to say that this group over here, that you are adamantly opposed to having exercise of any kind in treatment, okay? And over here, you think it's a good idea to have some kind of exercise. We haven't defined what that is, and we're being really all or nothing about this debate here. But I want you to just kind of throw out a few ideas about why you think exercise would be bad and why you think it would be good. Okay, so do we have any ideas to get us started?
In the short period of time that someone's in treatment, they need to focus on the ABCs of recovery, and exercise is all the way down there.
If exercise is a part of their disorder, you need to face it in a structured setting to see how bad it really is, so you can bring that to the light.
Do you have any?
Their health is compromised, and right now they just need to focus on getting well and not moving their body.
Okay, I'll go to the back and then I'll get you.
Just going to piggyback Tara, if they're doing only moderate exercise, then they can be exposed to the feelings that brings up and process through that.
Not only that, it can help like if they have edema and stuff like that, or bowel problems because of laxative abuse and all that kind of stuff. Teaching them appropriate exercise or moderation of exercise can help them learn how to have normal bowel movements without using the laxatives, or go through reducing the edema.
You're on our side.
They need to sit with their feelings. They need to sit.
That's right, sit.
So, chances are
good they're going to go back to exercise, and if we don't expose them to it at this level of care, we're just really ignoring the elephant in the room.
You know, they're
Now turn. There are many cases where anorexics then swing to become obese, and if we don't help them to learn how to exercise appropriately to prevent that, we're doing a disservice.
You know, we're really concerned that all the media messages out there, there's so many media messages, and they're going to go back out into that world. So for now, we need to teach them how they can sit and be present and mindful, and then they can go and back into that world of media hype.
So just like food is not good or bad, exercise is not good or bad. It's all about a distortion. You need to do it.
I wouldn't give permission for my alcoholic patient to drink 1 glass of red wine a day, even though it's proven healthy. So I wouldn't ask a compulsive exerciser to try to moderate their exercise.
Okay, we all give.
You may die from the lack of exercise, but you're not going to die. You don't have to have wine.
Exercise is from the devil.
Not if they can't moderate it. They can't over-exercise.
Most professionals, including psychiatrists, are not skilled in eating disorders, and exercise is good. So rather than send them out to unskilled professionals on the outside, let's teach them moderation inside.
What if they can't moderate?
So nutritionally,
If
they're not
alcohol
appropriate
can
for
moderate.
exercise at this point, and we're trying to restore their bodies. Why add more energy, and then we have to counteract that with more food?
Yeah.
Let's get them
So
restored.
at this level of care, it's absolutely
So is it
not.
undermining their weight restoration goals?
Yeah, very
Okay.
restoration.
Yeah.
Do we have a response to that?
Well, they're going to exercise in their
So that's where the
They're
therapist needs to get on there.
Any other thoughts? I saw your hand close.
Oh, that's actually what I was going to say.
The
At
goal
this level of
is to
care.
increase the oxygen in your blood and the mind-body connection, not all or nothing. I mean, preach our philosophy.
She's going rose
So it's actually appropriate to have movement. You don't have to classify it as all or nothing exercise.
So we have yoga,
Yeah.
and we have Tai Chi.
Which is
And they
exercise.
have
Which is exercise.
moderate
Thanks for
form.
being on our side.
Not exercise. No exercise.
That is exercise.
But the
Yoga and
people,
Tai Chi.
the patients who are restoring do
That's
not
excellent.
participate.
Thank you for
Patients who are
following our program.
restoring
That's
do not
wonderful.
participate, as Jackie said.
Isn't everybody restoring at inpatient level?
We hope so.
Everyone restores.
Unless they're exercising in their rooms.
Yeah, which
they are.
is pretty common.
Yeah.
We can assume that's
So we might
happening,
as
right?
well
Yes.
I think the reality is that it's a continuum, and there are some people that may never be able to go back to exercise because compulsion is so strong, but the majority may get to that place where they can do healthy exercise. But I do believe there's some that the compulsion is so strong it's going to kill them if they go back to it.
You have to be really careful. So let me ask you this. How many of you argued against your own perspective on this topic? Okay, because I assigned you to paid team, so I didn't allow you to choose. Okay. And as you mentioned, there already are some things that are happening that are exercise, and as an exercise educator, I would argue that all of that would count as movement. That one of our goals is that we want to expand that definition of what gets to count for exercise. But very good. You've got a lot of good insights about why that might be important. Some other things just to add. What about bone health? Is this population at risk for osteopenia, osteoporosis, and is exercise good for bone health?
Yes.
Certainly. Particularly thinking about resistance training, strength training, impact. Strength, flexibility, all of the things that are exercise is beneficial for in the general population. It also can benefit our client population as well, but we have to be careful. Decreasing anxiety. We talked about how the clients can get really grumpy, anxious, irritable. So exercise can also help with that. There are studies out there that suggest that exercise helps with program compliance, so that eating disorder clients are more likely to follow the nutrition guidelines in compliance to the other parts of programs be more present and mindful in group sessions and group process. And then body image. How many of you think that exercise can improve body image? I did a meta-analysis a couple of years ago looking at all the programs that use exercise as a form of intervention, and body image was found to improve, and particularly strength training was the most effective and had the largest effect size of all the types of studies that were done to show that. I think many of you mentioned the learning moderation. How can we teach that if they don't do any exercise, if they're on bed rest? Okay, the other thing that we should consider is just the harmful role that exercise plays in recovery and relapse. And as I've been working on my second book that causes treatment and prevention of eating disorders, when I worked on the relapse prevention chapter, I was very aware that exercise is harmful in the sense that tendency to relapse increases tenfold for those that are excessively exercising at discharge. So, we have things like history of suicide that are also, but exercise is just as powerful. And so we want to consider the fact that if we send them out there and they are still in their minds, excessive exercisers, or they can't wait to get back to it, they are significantly more at risk for relapsing. So we want to be careful about that. There's also some data that suggests that they are requiring longer hospitalizations, which is just not always possible. Don't always have the insurance support to justify or to allow to keep them in for as long as they need it. And it's something that is often one of the first things that comes about, and it's one of the last things to go away. So all of those things indicate that we need to address it on some level. But I'm sure that you're probably thinking we need to be careful about how we do this, and it's probably going to look different for different clients. And so we'll talk about that. But our first step is assessment. So how do we know if there's a problem in the first place? And within a treatment setting like Rosewood, it's pretty easy to tell. They're shaking their legs, they're kind of shifting around, they're not in an exercise group, but they're getting a lot of movement on their chairs, and the mood swings are crazy, and there's a lot of anxiety. So there's a lot of things that we can see. But one of the things that I like to know is, just off the bat, why is it that you work out? What are your motivations for exercising?
Weight loss.
Mm-hmm. Yeah, exercise. And that generally may not be something that they report right away, because they want to exercise, right? So you're going to tell me everything I want to hear. So you're going to say, oh, it's because I'm training for a marathon. Actually, I'm an ultra-marathoner. And so I need to get this amount of time in to be able to do these races. And I've been doing it for a number of years. It brings me a source of pride and confidence. And absolutely, I'm not doing it for calorie burning. Oh, of course not.
We just hear constantly, like, I'm doing this as stress relief. This is actually a positive coping tool for me. That's how I relieve my stress.
And that's good, because we actually want to reinforce that. And we want to champion those types of motives and really support those. But I've always thought that it's important to acknowledge that there are some other ones too. So if I was going to ask this group, and your particular personal exercise motives, how many of you use exercise as a way to get around? Raise your hand.
I have in my life.
Okay. So a way to use around. For example, for myself, I take the bus to work every day, so I walk to the bus stop. So it's about a 10-minute walk to the bus stop, so that's my main form of physical activity. How many of you improve your health? Use exercise. Okay. How about to control your weight? Okay. To relieve stress. To look better. To be social. Okay. To explore nature. Hiking. To train for a sport. Okay. So as you can see, most of you raise your hand at least once, but often more than once. Okay. And so we want to support that there's multiple motives as opposed to one sole motive. Because as we talked about at the beginning, we have shows like The Biggest Loser that are promoting one motive, and that's weight loss and ultimately appearance. And so we want to acknowledge that those other motives exist. Our goal, our hope would be that we can minimize those a little bit and then move the other ones closer to the top in terms of how we rank them. Now, when I did a study with women 20 to 80 years of age in the U.S., what do you think their number one motive was? Yeah, weight loss and appearance was top. Where do you think health was? That was fourth. Stress relief was second. Yeah.
How do you deal with it when it's a relationship with the sport? So they're actively involved in a college sport, or they're an elite athlete, and it's that loss. And exercise is a part of it. They don't see that, but you say, this is what I do.
Well, I deal with that on a very regular basis because I am the counselor for the University of Utah Student Athlete Wellness Team. And so we have athletes that we screen as they come in as freshman athletes. And as they are red flagged with issues, how do we deal with that? And that is a separate talk. You might want to have me back for a second presentation on that. But in a nutshell, just to give you a quick response, and we can talk more later, is we want to think about, is this sport instructive for their recovery right now? Is it getting in the way of recovery? Is this something where we need to bench the athlete? Or are they getting something from it, meaning social support from their team? Something that's keeping them wanting to recover because they want to go back to it. And so it's something that we deal with on a very individual basis. And with the Olympic athletes that I work with, this is a key issue. Because we have to consider, is this individual going to relapse that much further? Are they going to sink further if we just remove them from the team and take away their only other identity other than the eating disorder, which is their athletic identity? And so we have to tread lightly with that. So is there a way that we can keep them involved with team meetings, if their identity is a positive one? Or is it something where their coach and their teammates, the environment's so toxic that is feeding the disordered eating, and that maybe we want to start to have them shift and think about other identities or other forms of ways to participate. And so it can go either way, where we're either benching the athlete, they may have to leave the sport for a time, and in other cases where they're not participating at the same level while they're getting recovered. And then there are some athletes who are able to continue to participate, but the coach is in the loop, the other athletes are in the loop, and so there's kind of this team approach to how do we support this athlete while they're in this place. So it's a complex issue. Yes?
Oh, no, I was just
Okay.
scratching, sorry.
So one thing that I will also do to assess is instead of asking them what their motive is, because like I said, they will couch it, not lie, but they'll kind of really emphasize the positive things. So I'll ask them to draw their relationship with exercise. And this particular individual really hit it on the head because they said, you start off, it's really fun, it's enjoyable, but then it starts to get tough. I'm feeling like I'm in pain, I'm tired, I'd like to stop, but I gotta feel like I need to keep going. And so finally I get to the point where I'm exhausted, I'm numb, and I'm completely in pain. Now some of my colleagues that I work with would argue that the only thing that we want to assess is quality. I'm an exercise scientist by training, so I also believe that quantity is really important too. Certainly in the treatment setting, we're going to be spending a lot of our time addressing the mindset and the quality of movements, the motivation for movement, but we also need to look at frequency, intensity, and type of exercise that the clients are doing. As they come in for admissions, as we're sending them out, what are they going to be doing? How much? What's the intensity level? And the energy expenditure is key for folks like Alyssa who are doing the dietitian standpoint. How can they control what the nutritional needs are, especially for a client in the outpatient setting or intensive outpatient setting, when the exercise is not controlled for? So we need to know what that looks like. If there's weight restoration goals, we want to make sure that exercise is not undermining those goals. Running is probably going to undermine weight restoration goals, if I was going to make a blanket statement. It's one of the more intense, more vigorous types of activities. It's harder to regulate the intensity of that type of movement. So I would say, from that standpoint, it's one to be on the lookout for. However, clients can abuse any type of movement, including stretching and yoga. Okay? So we want to look at quantity. Now, how do we find out about quantity? How much exercise are you doing? How do I find out how much she's doing? we can ask her, is she going to tell us the truth? Is she going to tell, you know, like if she has a substance abuse issue, she's going to tell, oh, I have a glass of wine with dinner.
Ask her
Yeah,
husband.
and she's, yeah, so we'll multiply it by 10 if we're doing a self-report, but there are other ways. So how many of you are familiar with accelerometers or pedometers? Okay, so pedometers would track number of steps. Pedometers can be a little bit problematic because the screen's there, so that can be a trigger because it can show how many steps. Accelerometers are better, but they're more expensive. But basically, they are monitoring about any kind of movement, including swimming. As long as they don't dive in, they can wear it in water. It measures all kinds of movement, converts it over to caloric expenditure, and they can't see it. So it's about the size of a quarter with a comfortable belt. And you can monitor the movement, you know when they've taken it off. So you know when it's not there. So I've done that before as a way to monitor movement. And that can be really useful too. It's an objective measure. For the quality of movement, we really want to understand what are the motivations, what's the mindset, so we want to really hash that out. So that's about assessment, and we'll be doing that throughout the process, and that's really important to see. Are the motivations changing? Are they adding anything to this weight loss as a motivation? Are there other things that they're starting to do? Yes?
I just want to share this because I used to think, oh, it's no big deal that a client shakes their foot all day. So I put one of those on her ankle. She let me, she's willing to do it, because she was actually at the point where she was tired of shaking so much. And so it was about anywhere from 6 to 9 miles a day that she would shake. She was doing no other exercise, or the way she said she wasn't.
Yeah, and that's the thing that can be a concern, because there's all this sneaky in exercise. When I took over as the exercise director, I was basically, my initial job with New Life Centers in Salt Lake was to create exercise programs. And the first thing I had to do is get my hands around, or get a handle on what type of movement they were already getting. And what I discovered is staff learned very quickly that if they took the clients on walks, they were a lot better to work with. They were a lot more compliant, and they were a lot more manageable. And so every hour on the hour, or every time there was a shift change, there was another walk in the neighborhood. And they were lightweight walks, they were light intensity, but they were getting a lot of them. And so they were already getting all this movement that wasn't necessarily prescribed or structured or supervised. And so I had to understand that first. And then stretching, when I first came on board, was allowed. And so clients would be in the room, or they'd be out in the room, and people would be knitting, and people would be stretching and moving, and all this. So I'm thinking, we got to really understand what's happening and do some staff education too. So with exercise, in the past, as we mentioned, it was all about bed rest. Let's get them flattened. Let's make sure they don't move. Let's feed them. Let's get them weight restored, and then we can send them out. Now, there's a lot more awareness. There may not necessarily be a structured, really intentional exercise program like what I tried to create at New Life Centers, but there's at least a yoga class or some Tai Chi, or maybe Nia is used. But there's some classes that they can go to, and so they're doing some kind of movement. Exercise as a topic of therapy comes up quite frequently, and the dietitians are hearing about it all the time, the primary therapists are hearing about it, the staffs are hearing about it, and we're a lot more aware of it. And then the exercise as a medicine approach is much more popular now. In fact, the American College of Sport Medicine is having a whole conference on exercise in medicine in San Francisco in May, if any of you are interested in attending. And so there's this understanding that exercise provides us all kinds of things that a pill might try to provide, but it does it in a natural form. So that's kind of the then and now. Now, if we look at who is part of this treatment team for dealing with exercise, I've got a few folks that tend to be, or tended to be with New Life Centers, but in my personal opinion, I feel like everybody who works for the company, everybody, whether it's the IT person, whether it's the staff, whether it's the front desk, whether it's the cleaning lady, the custodian, it doesn't matter, because those impersonal, informal interactions are really powerful, and the clients can be most honest with the people that they don't see as their immediate treatment team. And so whoever we are, whatever our role is, whatever part of the process, if we can all have a consistent message about exercise, that's our first line of defense. That's our first way that we can really promote a healthy exercise message, and it doesn't cost us a cent. We don't have to hire anybody to do that. It's just about making sure we're all on the same page and we're not giving mixed messages, right? So that would be the first thing, is just making sure. And so what are the key points that we would want to promote? Well, first of all, just kind of making it intuitive. And I like the idea of this intuitive exercise because it parallels what we're trying to do with eating. We know that we may not get there right away while they're in treatment, that we might have to do some other things first, but our ultimate goal would be to eat intuitively, to listen to our body for hunger and fullness. In the case of exercise, listen to our body of when we're ready for exercise, when we need to stop. As simple as that. Increasing variety. How can we promote exposure to a wide range of activities and types of movement, and they all get to count? Every last one of them gets to count as a type of movement. How do we do that? And then moderation approach, not taking it too far, not doing it just to feel compelled, expanding our motivations, stopping when we're injured or sick. That's something that I've had to learn myself, as I turned 40 this year, and oh no, now I'm on the video. And so if my knee feels like it's tweaked, like if I'm going on a hike up the Cottonwood Canyons and I feel something in my knee, I slow down the pace, and if that doesn't help, I turn back. It's not worth it. I want to be a lifelong mover. I want to feel good. I want it to be something that I use. I don't want it to be something that's another pain or injury. Adding to those motives, having an exercise buddy is something that we want to encourage both ourselves as well as others to do, because it helps with the moderation and the intensity. Because there's one speed when our clients are feeling compelled to do it, and it's top speed, top intensity, and it may be controlled by that little monitor that they're seeing on their treadmill or on their ellipticycle. And then a rest day. That's probably one of the hardest things that I've had to promote as an exercise therapist in the outpatient setting. When I set up an exercise plan for the clients that I'm working with, and they say, well, what about I need to have something on that day? No, actually, let's have this be a rest day. Not a single bit of movement is scheduled for that day. It's just a day where you can do something else. So being intuitive with exercise is all about, how many of you have heard the built environment for exercise? It's kind of a hot term right now with exercise scientists, where you're just using your environment. You're not joining a gym. You're not buying an exercise pass. You're just doing with what's there. So if there's a path, you use it. If there's not a path, you build it. And it's all about, using, what's there, what's free, what's accessible, not needing a lot of equipment. Doing it locally so it doesn't take a lot of time and planning, but you're just doing it. Knowing why you're exercising. It's important for our clients to check in with themselves. Why is it? What's in my mindset right now? What is my mood? What am I thinking? What am I trying to accomplish right now with exercise? And with this one, when I would be leading classes, like when we would be doing curls, I could look into the eyes and I could see that, Cheryl, she is in the zone where she is just detached, disconnected, and all she can think about is how much can I get in here in this class. And so kind of checking in about that, understanding what it is that's happening, and being able to converse with them. So if you already have a yoga class in place, what are the protocol in place for monitoring if somebody's really getting like Cheryl and they're starting to really push the yoga postures and they're really taking it too far? What do we do with that? And then encouraging our folks to stop when they're pain, tired, injured, and having some flexibility around vacations. Others would be celebrating the enjoyment of movement. Movement can be fun if we don't have it so regimented and so routine. And if we have a lot of variety and diversity in our movement, we can really enjoy it. If we allow ourselves to count things like gardening and moving and being out there and just walking from point A to point B, which incidentally, functional movement was the top reason for exercise among the Hungarian women, 20 to 80 years of age. That was their top reason for exercising. So if we can be more like the Hungarians in my study, and really enjoying it. The other is thinking about how we feel as opposed to how many calories are burned. Now I know, talking to you all right now, and you're in the trenches, and you're thinking to yourself, that sounds really nice. Yeah, that is great. But the reality is we're not anywhere close to that. And how do we get there? So I'll tell you a little bit about that. But this I just wanted to kind of share with you so we're all on the same page about some of the types of messages that we can promote through our casual conversations with folks. Does that make sense? Are there any questions? Okay, now, so kind of getting to some more nitty-gritty. Avoiding weight-based judgments. One of the things when I came on board with New Life Centers is they had this great exercise facility. They had different machines, ellipticycle, like a bicycle, and some other things, but they all had the systems where they could watch how many calories they're burning. And so I thought to myself, yikes, we're basically the original plan was to just send them down. They were going to be moving around and looking at this and being triggered by it. So we disabled those devices. So if you have any types of machines or anything like that, that would be something that we would do first off if we had a controlled setting. But what do we do in a gym setting? So we've kind of got to train our individuals if they're going to be going out and using equipment that's going to have numbers on it to be able to deal with those numbers. So that would be our ultimate thing. But we want to avoid number-based judgments. So whether it's the machines themselves or whether it's the numbers on the weights that they're using. Another thing that I had would be that she would be looking at what I have a 5, and she says, well, I'm going to make sure I get the 8 then. And so we have this little comparison competitive thing going on. And so we want to look at how we can decrease the number-based. So if we're going to look at setting up a very strategized form of exercise education, maybe you already have this, but this is what I would recommend, and this is what I would reinforce if you're already doing it. So the top one is having psychoeducation all around exercise. So I don't know if you already have a group that is all about providing psychoeducation about benefits of exercise, healthy exercise, but it's all exercise.
We do just a nutrition group at Capri about exercise, but it's more asking, what was your exercise like in the past? What would you like it to be in the future? And then we go over like a moderate amount of exercise would be this.
Yeah, so that's wonderful. So having some type of psychoeducation where it's not just a yoga class, but they're actually talking about it, talking about their relationship, talking about motivations for exercise. How can exercise help promote self-esteem? How can exercise both help and hurt anxiety? So kind of thinking about all of these things as they relate to their eating disorder and their own sense of well-being. Supervised, we'll talk about that in a moment, but the key points here would be supervised, prescribed, individualized, diversified, medically clear. Who does the medical clearance? Is that person in the room? Okay. Okay. And then exercise challenges. So in terms of the psychoeducation is great because we can provide that to anyone regardless of their medical status. So I am not the person who does the medical clearance. On my outpatient treatment team, it's the doctor that provides that, and they determine when that person is ready. When I was working with the residential inpatient, there was somebody else that did that. But regardless of how low or how much weight restoration is needed, the psychoeducation is a piece that everybody can be involved in. And it's really important for them to be involved in. Because they may not be at a point where they can even have, the stretching or the yoga class. Examining their relationship for exercise, the benefits as we were talking about. The supervise. Now this is where, when I went to New Life and found that the staff was taking them on walks and things like that, it wasn't structured all the way and it wasn't necessarily supervised. And I have consulted with other treatment programs before where they'll give passes, gym passes to their clients, and they'll send them out like on, kind of like a visitor pass where they go out with their family, but they'll get an exercise pass. They can go to Gold's Gym or something and go work out. Well, if it's too soon and there's not the supervision, that can that can unfortunately contribute to the potential for relapse. So we have to be kind of careful about that. So we just want to be really strategic about how we do it. But supervises are key. So our yoga instructor needs additional training. Our Tai Chi teacher, our NIA instructors, all those folks that we're bringing in to do our exercise, we want to make sure that they're knowing what to look for. And ideally, that we have the staff that can also watch for someone like Cheryl who's getting in the zone and maybe needs to be taken aside and process a little bit. So the supervise is key, and that way we know exactly what's happening. We're able to document and indicate in our clinical notes what happened. It's not uncommon in the sessions that I do for somebody to start crying in the middle of an exercise session. And you might think, well, why would that happen? They're finally getting to move, right? Well, no, I mean, there's a lot of things going on. In one case, we had an exercise class, and we get in all of our exercise gear. So I'm not in the proper attire right now. But we want it to be exercise, so we put exercise shoes on and clothes that are not triggering but are comfortable to move in. And so at one point, there was a client who started crying, and I said, we talked about it after in the process group, and she said, I felt like I could actually feel it, and it was so little compared to how much I did before. And so she said, I was surprised because I could actually tell that I was doing something. But, how could I do that? And so actually she was being a mindful exerciser, but for her, it was, just extremely uncomfortable, stressful, that she was doing that. But ultimately, we want to know what the energy expenditure is looking like. We want to make sure that we have a good gauge on that. Prescribed, thinking about exercise as a dose. What type of exercise, how much exercise is appropriate? In some cases, 0. In some cases, bed rest is needed, especially in an inpatient setting. Sometimes, and I found this to be the case quite a bit, if we have somebody who's a severe exercise over-exerciser, they've been doing it for, I treated a client who was 48, and she had been over-exercising for about 38 of those 48 years. She needed to just take a break from it. Now, we continued the psychoeducation, we continued the process group, we continued talking about it in primary therapy, but she really just needed to sit. And that was kind of your argument over here. And so we do have cases like that where we need to kind of have a gradual introduction or reintroduction to exercise that may need to happen. But thinking about a prescribed amount, and that might look different for each person. So it also needs to be individualized. And this is probably the biggest challenge in terms of implementation. Because let's think about it. If we run groups, what are some of the groups that you have in here? Do you have a DBT group?
Body image.
Yeah, a body image group. So if you run your DBT group, do you have each client learning a different skill? Yeah, everybody's learning together. And so the individualized part can be something that can take a little bit more time to figure out. Does that make sense? And so we want to be really careful that we're working that into the treatment plan. But in terms of actually the implementation of groups, it may take a little more creativity about how to make that happen. Okay? But ultimately, we want to increase it as gradually as we safe. Our ultimate goal is to do no harm. So if we have any question about it, it's best to not have them start moving until they're medically cleared and ready. Okay. Diversified, we talked about trying to be more intuitive exercisers, exposing them to a variety of movement patterns. The most effective way is if we can get them doing something they've never tried before. Because then they're thinking about learning the skill. And so sometimes I found that teaching people how to swim can be really effective. Because they're so focused on stroke technique, they're not even thinking about moving or is this burning calories. They just want to stay on top of the water. They don't want to drown. Okay? So it can be really useful if there's a skills training component that you can do. This could be anything, fencing, I've had taekwondo instructors or self-defense instructors come in, and we don't necessarily do a lot of sparring, where there's potential for injury sometimes, but just doing the movements or the poses, and so they're really focused on those skills. We'll do things like Nia, Zumba, things that.
What is Nia?
Nia, you haven't seen Nia before. It's a combination of mixed martial arts, dance. It's very playful movement. There's a lot of scarves involved, and you can do it at any level, and that's the neat thing. So at New Life Centers, we had these Nia instructors that would come in, and they would do a session, and they play this empowering music, and it was women in this case, and they were jumping around, and they were dancing, they had their scarves, and it just builds your spirit and builds your mood. So it's incredible. But it can be used, and it can be done at the advanced level too. So that's where it was up, where we had to really work with the instructors to make sure they could tamp it back.
So I've noticed something really consistent, and that's when maybe we'll have a little more active rec, even if it's indoors, and they come in and they're crabby. And a lot of times they don't want to come to rec. I'm not in a happy mood, I'm not in a fun mood, and I don't want to be here. And we get in here and we get the music going, we start to play these fun dance type games, and inevitably almost every person in the room brightens, and when they leave the room they're in a completely different place. So it's just so effective.
Absolutely.
And fun loving, being playful is so key.
That's right. I mean, really getting them out of their routine is the goal. And the music, I know you have a music therapist, and so I'm sure she knows the importance of music. But really using that, and one of the things that I'll do even in an outpatient setting is I'll look at prescribing beats per minute for the song. So, it's really important for us to retrain our clients what would be a walk that would be acceptable or appropriate. So, so I actually literally go outside the office and we're walking, and I have them show me, and then we retrain them to walk in a form where they're not going to get hurt and where it's the proper intensity. And so we're actually literally moving, so that we have a sense of that and they have a sense of that. And if there's something that we can do with music where they can put it on their iPod to keep them in the groove in terms of beats per minute, and that can be really effective too. And so, yeah, the music is really key. Would you think of team sports as being something that you'd want at an eating disorder facility? I mean, that was something I thought was important because it's something we get away from being a kid. And it's terrifying, of course, for some folks. But we get in there and we're playing some games. Some of them they've never played before, but they're using communication. So we can teach skills like communication, teamwork within these team settings and these team sports. Just skipping down the street. You've got a beautiful setting here, so there's so many things that you could do just right here in your backyard. It's just amazing. You don't need a piece of equipment here. And water aerobics is great too, because naturally the beats per minute stay at about 120 or so in terms of the music that you're playing for water aerobics, so it's a very nice type of modality to use. So medical clearance, we've got our person that does it here, and so that's the most important. But I mean, I'm sure all of you know that we just need to be really careful about that. If there's a need for refeeding, we want to be conscious of that. Weight restoration status. If they're medically compromised. I had a client who was running marathons. She finished a marathon, checked in, and her potassium level was so low she needed to go across the street to the hospital. But just imagine that, she just finished a marathon. And so just because they've been actively participating doesn't mean they need to keep participating medically. And there have been some body mass index studies that have shown 14 and above would be safe for exercise. But I think it generally will be your medical physician that should do a comprehensive medical assessment. So I would caution against using one marker to make that decision. Okay, exercise challenges. Do you have social challenges that your clients do where they go shopping for clothes, and restaurant challenges? Do they have exercise challenges? Yeah? Yeah, good. So having an exercise challenge where they're going out and they're trying different things, they're addressing some of their triggers, whether it's mirrors at the gym, other exercisers, certain types of yoga postures that they just find particularly triggering. As you know, exposure therapy is pretty key with some of our other skills that we're trying to teach, but exercise is no different. So we want to include our goals. We want to make sure we have process time. So we want to be very intentional about which staff goes to the exercise setting. If there's some kind of off-site that happens, we want to make sure we have that person. The primary therapist needs to be involved in that discussion, as well as the rest of the treatment team, and deciding a client's readiness for an exercise challenge. Usually happens a little later on in treatment. Yeah.
Sometimes the challenge is watching it, because there was a movie that we would show, and lots of exercise, so they would just be triggered watching it, and that was an emotional group showing that. It's really good to do it in a supervised setting, because, and I've had people just watch it and weep, or have to leave and so forth, just the video of people exercising.
Absolutely. I mean, it can be any number of things. And ultimately, what the challenge is can be individualized. So this is an area where you can really focus on the individual's needs, what it is, whether it's just watching, whether it is just walking into a gym, whatever it is. And then just to kind of wrap up, in terms of exercise
You're good
sessions.
at reading your audience.
Yep.
What was your first clue?
Here's some things that we've done. So starting off with a psychoeducation lesson about mindful versus mindless exercise. Taking a meditative walk where they're encouraged to use all of their senses, including their sight, smell, hearing, all of it. And then debriefing after. So we talk about our mood during, before, and after. And then a second sample lesson would be self-esteem and exercise. And then having a whole lecture/lesson interactive about that. And then having some self-defense. And then having some debrief about the empowerment of movement. So those are just some samples. I'm going to kind of flip through and say that in conclusion, we have some fighting forces to what we're trying to promote here. And you know that versus based on food and body image, and certainly exercise is no exception. So we want to make sure that we have some assessment tools in place, using wide weights to measure exercise and relationship with exercise, as well as understanding the role that exercise education can play in treatment. And this is my contact information. This is probably the very best way. Email would be the very best way, but you can certainly call me also if you ever have questions. And I have a group on campus that I've started 10 years ago that's called SPEAK, Students Promoting Eating Disorder Awareness and Knowledge. And it's all about doing outreach in the community, eating disorder prevention, awareness, and so we do a Love Your Body Week every week. And I know you guys are kicking off yours. And so I'm hoping that the video will work. So I brought a YouTube video that we created last year for our session, which was called Maximum Impact. And so it's entitled, What Do You Love About Your Body? So it's just 3 minutes. And they went out and they talked about the one.
It seems like the message we get from today's media is that our bodies, the way
Yeah. It does it sometimes on YouTube.
I was going to ask you a question, should I ask it now while we're waiting?
Here they are not good enough. We are being manipulated to conform to the social pressures of being and looking like the media's ideal man or woman. Well, the ideal body doesn't exist, and we're not buying it anymore. We are giving ourselves permission to redefine and incorporate all body shapes and sizes as lovable and beautiful. If you're fed up with the media's manipulation, then tell us, what do you love about your body?
I don't know, I like a lot of different things about myself.
I like having really clear skin.
I love my hair.
You never know what you're going to get.
Legs. I love my lips, and I love my eyes. I love my blue eyes. My height.
My eyes.
I love that I have just one dimple. My smile.
My physique in general.
My muscles. My skin.
He was a swimmer.
Everything.
just love that I'm me.
Just how many times I can be surprised by what I'm actually capable of doing.
Yeah, it gives you the solid. Super short, super strong, and way skinny. It's good the way you are.
That was really making myself conscious about my appearance. So sometimes it's hard to feel good about my body, but at the same time,
It's unique. Who I am.
that's part of what makes life so fun. I'm excited.
I'm proud to be who I am, and I know whenever I look in the mirror that I'm just who I am, and I'm really confident in this.
So what do you think about media's manipulation and how they portray what our bodies should look like?
I really think that
Just allowing it to catch up. That's my office.
I love the scenery out the window on one of them. You could see the mountains.
Yeah, that was not my
Wow.
office.
Beautiful.
This gentleman actually is getting his master's in health education, and he wants to promote body image in men. So it's but in his quote, he talks about working at Abercrombie and Finch. And, so our whole idea with this video was to try to promote a counter message, because we always say, what is it that you want to change about yourself? Instead of celebrating what it is that we love. So we have gone away from calling it Eating Disorder Awareness Week at University of Utah. We call it Love Your Body Week.
Even though you see we're over that.
It's all about promoting self-acceptance, loving your body, and try to make it as broad as possible so that the message can apply to everybody. And it sounds like you guys have a lot of really good events planned. Yeah.
Can I just ask a question, because it's kind of bugging me, and I'm just wondering what your experiences are, but have you found it to be harmful, helpful, or indifferent to use the word exercise? Because it implies the science behind it, and so sometimes that works for clients, but it also implies more cardiovascular, because I've just started to steer away from using the word exercise and use activity or movement instead. And I'm just wondering, because I've noticed all your slides, does it purposely use the word exercise?
Yeah, it is actually. Thank you for that question. So initially when I first started developing the program, I thought I was going to go with movement. And as I started really examining the literature and the science, it's kind of evolved to the point where we're trying to promote exercise as exercise, what gets to count. So we're being consistent with American College of Sport Medicine and what they're hearing in terms of what they need, in terms of their recommendations for physical activity. Physical activity I think would be fine too. But if we use movement, it somehow suggests that it's something less than exercise. So they're just doing this movement thing while they're in here, and then they're going to do exercise when they get out. And so that's where when I first started doing the classes, I would have staff that they were dressed in the things that we have to wear to be in here. So they would have like women's dress shoes on like this, and they would be on an exercise ball, and it wasn't serious. And so we had to change it and say, oh, we're really moving today, we're exercising. And so it is kind of about we're exercising in moderation. But with that being said, trying to help them figure out ways that they can exercise and move no matter where they are, so they don't feel like they have to be in the gym to do it, but that they can do it just as part of going about their business or where they need to go.
That was like an aha moment in one of those groups. is that, oh my gosh, you know, we even got a little bit out of breath. You know, I mean, we used our bodies, and yet it wasn't like going to the gym or going to some class, but we had fun. And so, you know, that was a light that came on for them. That's what I think we should promote is, you know, being able to be playful and use your bodies and still benefit your body without having to be some routine, you know,
Exactly.
structured class.
Right. And we want to think about how can we help them so they understand how to replicate it once they're not in a residential setting or even an instance of outpatient where they can go to a group. So how can they do that? You know, either how can they connect with a friend that can move with them and exercise with them, or is there some type of class that is available that would be similar to what they had in here? Or can they do postures? You know, how can they continue to have that playful spirit?
It'll probably keep up now.
Yeah? Okay.
She's kind of stupid. I think it's actually really sad. I think it's wrong. It is not real. I don't very healthy.
Just about a wedding about a week or so ago. People wanted me to edit, to change, you know, their images and all their photos, and I'm heavily against that.
It just seems really unattainable, and it's causing eating disorders and people to like mess up their lives just for like a picture perfect body that you really can't get.
It's giving a lot of people in our country the wrong idea of how to be healthy.
Just talking to a lot of people and their own personal tastes of what they think it is to be attractive, they really don't value that.
I work retail, and they're marketing it unrealistic. It's all airbrush, and they even tell us that.
It's just impossible to achieve. I just don't think I'm to those media messages, but just give us you and distort that media message. Promoting this kind of ideal within our society, it makes it extremely difficult for people to engage in healthy behaviors and really take care of themselves.
It's putting people who are so beautiful, no matter what shape or size you are, and making them think twice of what they should be as a person when they're beautiful just the way they are.
You don't have to have like...
We're almost there.
Can I comment on that photographer? I also do photography, and my goal is to like capture someone's spirit, you know, their true spirit. And I can't tell you how many pictures people say they don't like because of their wrinkles, or because of their neck, or because of the bags under eyes, or their hair, or their, I mean, it happens all the time, and it's always, can you do this? Can you fix this? Can you make me slimmer? And that's one of the reasons I will not do weddings. You know, I mean, women especially, and not so much men, but women are awful when it comes to
Well,
know,
even
accepting
men,
of themselves.
even men, you know, if they feel like the shirt is, you know, pouching out certain areas or the way they're standing. Yeah, very good point. We're under a minute as far as the video.
To be sensitive, to be handsome. Bodies are acceptable at any size. It's up to us to keep us loving ourselves, no matter what society or we really need to focus more on how we are, what we act like, instead of what we look.
We should be happy with the bodies they have.
That's pretty much, it's pretty close to the end. And this was created by the filmmaker was in a fraternity. So it was interesting because I had no control over the content or anything like that. This is what the students came up with. You know, it's students and professionals in this group, but this was, you know, something that they did on their own, not for credit or anything like that, for this week. And the idea behind it was really that we can have events all week long, but only certain people will come to the events. And so we had 3,000 hits, and then so much.
Thank you.
Cash thinks it's about him.
Oh,